PCORI is the Patient-Centered Outcome Research Institute's Pediatric Hypertension Research Group. So adults with high blood pressure, even though I do care for them on Tuesday afternoons, are really is a little bit out of my element. And these slides were originally put together by Dr. Jackson Wright, who is very distinguished and happened to serve on the 2017 AHA ACC committee. Unfortunately, he was not able to be with us here today, but he will be joining us later in the ECHO session. So I'll preface that. And so today I'm going to do a brief didactic session of about 18 to 20 minutes going over the guidelines. Not every single recommendation in the guidelines, not every single detail, but essentially what the new features are. Now I'm going to turn things over to Adam, who's going to present a case to you similar to what we will hear about throughout the ECHO session. So ECHO is a case-based learning program. The case we're going to present has a lot of detail that you may not be able to acquire from your own patients. Nevertheless, I think it will give you a flavor of the types of information that we want to gather. Then we'll stop and we'll allow people to interact based on that case, ask a few questions, and hopefully Adam and I will be able to answer them, maybe not. But one of the goals of ECHO really is to learn from each other. So if you have a comment about someone else's comment, that's a good time to bring it up and say, oh, here's what I would do in that situation. There's nothing wrong with that at all. The first session, everybody is a little hesitant to speak up, but once people start to speak, we usually run out of time. So what I'm going to advise is that I may actually just call on a site and anyone is free to speak. And if you're not comfortable, that's fine as well. So with that introduction, Shannon, maybe we can move on. So in terms of disclosures, they are listed here. I don't have any disclosures with respect to this, but you can read through these and I'll give you just a moment to go through that. Okay, the next slide. So this is just a list of the high blood pressure guideline writing committee, and many of these folks are extremely well known in the world of hypertension, and Dr. Wright, whose slides these are listed. I happen to have the privilege of working with Dr. Dan Jones at the University of Mississippi, who was PI at the Jackson Heart Study, so extremely a distinguished group of physicians, scientists, nurse scientists from many different disciplines. Next slide. So like most good practice guidelines, this guideline addresses very, very specific questions. And these are some of the questions that they looked at. One deals with self-directed monitoring of blood pressure. As you know, it's often difficult to get patients to come in, especially for repeat blood pressure values. And the value of self-monitoring is something that was addressed by this guideline to some extent. The most important change with this new set of guidelines is the optimal target for blood pressure lowering, which we'll talk about in quite a bit of detail over the next few minutes. And of course, drug antihypertensive classes, not a lot of changes in what's recommended except for one major change, which I'll discuss in a moment. And when do you initiate treatment? How do you initiate it? And what are the comparative harms and benefits? So some of the questions that are addressed in the guideline, we won't address all of these in explicit detail because of limits of time, but the highlights of the guideline is going to be the focus of this presentation. So next slide. So here is the fundamental evidence that underlies one of the major recommendations, major changes of this guideline, and that is if you lower systolic blood pressure to less than 130 millimeters of mercury, there is a benefit in terms of the relative risk of major cardiovascular events, including myocardial infarction, stroke, heart failure, and a composite of those. And these are all significant decreases in relative risk. The confidence interval don't overlap one. And so there is some benefit to a lower target. Even in whether or not in an individual patient this would make a huge difference, of course, is one issue. But from a public health standpoint, if we all adopted this target, and if we all lowered our patients' blood pressure to the systolic threshold of less than 130, it would have an enormous impact upon the incidence of heart disease in this country. Next slide. So that's one piece of evidence. Now let's go through some of the recommendations, and these are things that Dr. Wright wanted to highlight in this. The second major recommendation, I think, is that out-of-office blood pressure measurements are recommended to confirm the diagnosis, titration of blood pressure lowering medication, in conjunction with telehealth counseling or clinical interventions. This is a hot topic right now, out-of-office blood pressure measurements. We're going to address this a lot next week as well. Obviously, out-of-office measurements are more convenient. There is also evidence that because of white coat hypertension, they are more accurate. As we'll discuss next week as well, out-of-office measurements are also more predictive of cardiovascular events. So they're superior overall. We have blood pressure all the time, and if you measure it only once a month in the office for a couple of minutes, it doesn't make a lot of sense. So there is more emphasis on here. What you will not find in this class of recommendation one recommendation is the use of out-of-office measurements for diagnosis itself. So somebody who hasn't seen a physician, has 3 or 4 out-of-office measurements, all of which are high, comes into the office for the first time, you still need to take their blood pressure in the office and then do some confirmatory out-of-office measurements. You cannot rely upon it for diagnosis. I'm hoping that that will change in the coming years. Next slide. Initial medications. There are some notable changes in this guideline with respect to initial treatment. First of all, lifestyle modification is emphasized significantly. This is getting more and more attention, especially in terms of salt reduction, which we will talk about later on in the course as well. It used to be about 10 years ago that treatment with medications was almost a reflex because, oh well, you know, people are not going to modify their lifestyle. But salt reduction in particular is so effective, in fact, as effective as a full dose of one of these agents, that it is a first-line recommendation. Thiazide type diuretics, etc., are still recommended as first line. The major change in terms of diuretic treatment in the new guidelines is that chlorthalidone is recommended over hydrochlorothiazide because there's more conclusive evidence of its blood pressure lowering effect and of its effect on cardiovascular events. So it's a significant change. And actually, Dr. Wright has individually changed my practice entirely. I now go to chlorthalidone as my first line agent and have for the last couple of years. Next slide. So here are the most important changes of all, and we talked about that lower target from an evidentiary standpoint, but when we talk about targets, there are 3 different types of things to remember. One is, what are the diagnostic thresholds? You know, at what point do I make a diagnosis of hypertension, stage 1, stage 2, etc. The second thing is, what is the target for treatment? So even if somebody has a very, very high blood pressure, and of course, we know they've got hypertension, but what point do I have to lower the blood pressure to? Then that, of course, could be different depending upon their overall risk, etc. So there's the diagnostic threshold, there is the treatment threshold, and of course, there is the, there's a threshold of target for treatment. And then there is a third threshold, remember, and that is, what is the target for initiation of pharmacotherapy? And all of those can be different. So we have a diagnostic threshold, a target for treatment, and a threshold for pharmacotherapy. So just because somebody's blood pressure is above the 130/80 threshold doesn't necessarily mean I'm going to initiate medications. Maybe I'll start with lifestyle modification, and maybe I'll continue that if they're only slightly above that range. So that's why the guideline is a little confusing, and you have, in other words, 3 sets of tables with 3 sets of numbers. But let's start with that diagnostic threshold. And on the left-hand side, on the 3rd or 4th column of this particular table from JNC7, we labeled that range of 130/139 and 80/89 as pre-hypertension. Now it's stage 1, stage 2 begins at 140, and stage 2 remains at 160/100 or higher. So stage 2 hypertension, the more severe form, is actually what we used to call stage 1 hypertension. Next slide. So less than 130/90 is the blood pressure level used to define initiating drug therapy and to define the blood pressure target in nearly all clinical settings. Now, you can initiate blood pressure, a target of 130/80 or less, especially if they have an ASCVD. This is the calculator of an overall cardiovascular risk, a 10-year risk of 10% or higher. If you have confirmed hypertension, but you don't have additional cardiovascular risks, a target of 130/80 may be reasonable. So it's okay to be a little bit above that, depending upon their level of cardiovascular risk. Next slide. Use the CVD estimation, the atherosclerotic cardiovascular disease calculator, to determine whether they fall above and below that 10% risk. It is widely available on the AHA, American Heart Association website, elsewhere as well, very, very easy to use as well. But that is one of the most important recommendations, is more widespread use of the calculator. Next slide. So now here's another major source of evidence. There used to be a difference between the target and the threshold for diagnosis in older patients. Now we are adopting that 130/80 target, 130 especially systolic target, across all age groups. And in fact, there is better evidence in the older age group for a benefit of reaching that 130/80 target. Next slide. And so this slide, I think, is a little bit complex. The only point here that I'd like to make is that the new recommendations from AHA, ACC, which are third from the bottom there, the 2017 consensus graded recommendations, that adopts a target in the general population, 130/80, 130/80 for high-risk groups and those with CKD and diabetes mellitus, across the board, making it very, very simple, is fairly consistent with recommendations from other organizations, especially the more contemporary ones. And of those, I would think of the European Society of Hypertension, which I think is also a reasonable approach. You know, you adopt a target of 130/80 if tolerated, and then a uniform approach as well for those with comorbidities or those who have other high cardiovascular risk. So across the board, the targets are fairly uniform. Next slide. So the most prominent update is a reduction in recommended BP levels as a diagnostic tool, also for initiation of drug treatment from 140/90 to 130/80. We are looking at a uniform cutoff across all age groups. It is also the target that is used for initiation of treatment depending upon their level of cardiovascular risk across the board. So if they have no other risk whatsoever besides hypertension, you may want to hold off. It says you might want to initiate treatment. You may want to hold off on treating with pharmacotherapy right away. Use the ASCVD calculator very often to calculate that risk across patients. And finally, I think office BPs can be relied upon for confirming the diagnosis, monitoring treatment. I also strongly believe it reminds patients that they have hypertension, and some of our older patients, of course, measure their blood pressure with a great deal of enthusiasm, as you know, sometimes twice a day, sometimes multiple times a day, sometimes in response to medication, and I don't think there's anything wrong with that. 2/3 of all adults across America with high blood pressure have a home BP machine, so a significant number. And I know that my patients, that's extremely common. So being conscious of your blood pressure, I don't think is necessarily a bad thing. What we cannot yet do is rely entirely upon home BP blood pressure measurements for diagnosis. We use it for titrating therapy, etc. Next slide. Summary and conclusions. What effect this guideline will have is significant. We will have many more people who qualify for drug treatment, and roughly almost 8 million who will require intensification. There's greater use of chlorothalidone and spironolactone as more effective first-line agents, greater emphasis on lifestyle modification, as we'll talk about more later on in the series, especially in salt restriction. The other thing that Dr. Wright added to this slide set is simply that we think of hypertension as a cardiovascular risk. However, it has been shown quite conclusively from the SPRINT-MIND trial that a lower systolic blood pressure target among patients with Alzheimer's disease results in a slower rate of cognitive decline and dementia overall. So blood pressure treatment is not only necessarily for preventing cardiovascular events, but can slow the progression of dementia. So if you're not convinced about the SCVD calculator, this is another reason to do this as well. Next slide. Thank you very much. I think we are right on time, maybe a couple minutes over. And I'm going to stop at this point. I will usually stop and see if there's any questions that I can answer about that presentation and about the guidelines in general at this point. We'll give you a couple minutes.
So, OC Total Health and Wellness, we have a couple questions.
Sure.
Would you recommend changing people who are currently on hydrochlorothiazide to chlorothalidone, or mostly just for new starts or individuals not achieving adequate results at this time?
So great question. I actually had a chance to speak to Dr. Wright and Dr. George Bakris, who's going to be joining us later on, about that very question. His recommendation is no, do not switch them to chlorthalidone. However, when you initiate treatment, start with chlorthalidone, especially if they're well controlled on hydrochlorothiazide. There's no reason to switch them over. A lot of patients are on that 12.5 of hydrochlorothiazide as an adjunct to other agents, and their blood pressure is well controlled. They've been taking it for years. There's certainly nothing wrong with that.
And one additional follow-up question, kind of related for the out-of-office monitoring. Is there a recommendation or a preference between wrist and or arm cuffs?
Yeah, so we'll be speaking about that a lot next week. Definitely an arm cuff. There is an entire organization that validates devices and protocols for blood pressure measurement. And even though the wrist BP measurement, even finger BP measurement is showing some promise, it's not yet a validated measure. So a validated arm measurement with the patient having some degree of instruction in how to do this, especially in the morning, at least a consistent time every day, is what's recommended this time. And we'll discuss that in detail next week.
Okay, thank you.